you have to apply all that you have learned in the general system, right? The pathology, anatomy, physiology, especially the histology part, isn't it?
Yes.
Because like when you have pathology lectures like mine now, we actually do take a lot on the appearance of the organs. So I expect that you know what is the normal size of organ. For example, how does the uterus, ovaries, what is the normal size, so that when I show you the abnormal ones, you should be able to appreciate, right? Okay, because that's covered in the earlier part of the modules. In terms of microscopy or histology, I think you have learned some basic in your first semester, perhaps. Also in general pathology, right?
Yes, doctor.
So you should know like what lines your skin, your reproductive tract, and like your respiratory. And I think in general pathology, we also have been taught what happened to this normal lining when disease takes into place, the inflammation, the neoplasms, the different type of neoplasms. Because now that you are in the system, basically you are applying those knowledge into the system, kan? Right? Okay, like in the past lecture on Monday that I have given you, we talk about cervical cancer. What is the expected changes, the pathology changes in terms of what happened to the organ? What does it look? How does the mass look like? Is it benign? Is it malignant? And on microscopy or histology, what is the expected finding? Right? How different are the cells now? Now they are already cancerous. How different is it they are from uh, normal tissues? Okay, this is all about applying your general concept of pathology into the system. So like for this your modules, you are doing reproductive now. Next module is urinary, correct? Right?
Yes, doctor.
Yes.
Is everybody on? Can we start now? It's already 11:30. Boleh
Okay,
ya?
doctor.
Okay. This lecture covers the common tumors of the breast. I have a total of 77 slides, but don't be frightened. There's quite a lot of features there, but I will not elaborate on every single slides. Yeah, we'll focus on the common tumors. There are other non-tumor condition that I put it into the lecture because I'm not too sure where it's covered. So those should be notes and guide to you for you to go back and read up. Okay, there are other conditions affecting the breast. Is that okay? Right?
Yes, doctor.
Okay, doctor.
So yeah, we focus and discuss about the tumors, but the non-tumor part we might skip and feel free to read it up later or as your notes, extra notes. All right. What do you think a patient with breast tumor will come to you as a treating doctor? What do you think that will be their complaint?
There's a lump. A lump.
Yeah, doctor. I have a lump in breast. Any other expected
Pain.
pain? Yeah, correct.
Police charge.
Yes, nipple discharge. Don't forget that. Huh? Any other complaint? You think?
Weight loss.
Yeah, the general system, of course. Weight loss, unhealthy feeling. Lagi? Anything else? Sometimes they don't complain on the mass or they didn't notice, they as a layman, they're not too sure how actually breast examination is done to detect a mass. Until it's a sizable growth, some patient did not notice there's a lump. We will detect the lump, but they come with some other complaint, like as you said, nipple discharge. Any other complaint, you think?
Doctor, what about dimpling
Maybe
of the
changing
breast?
color.
Sorry?
Dimpling of the breast.
Yes, yeah, skin changes, Skin changes, that's right. Any other complaint apart from complaint swelling or the breast itself? Do you think they can complain with some other masses or any other different site, nearby site?
At axilla?
Yeah, what about the axilla?
Maybe the lymph nodes, yeah.
They complain swelling in the axilla. That we have had patients who complain that they didn't notice anything wrong with the breast, but they claim, doctor, I've got the swelling in the axilla. Why do you think that happens?
Metastasis.
Yeah. What does that mean? The tumor?
Tumor spreads via lymph.
Yeah, sometimes the tumor can be quite small and not detected by the patient. But of course, we as a trained clinician, we can detect. But sometimes the patient did not notice there's anything wrong with the breast, but they present with a lymph node swelling in the axilla. Basically because as lymph node is part of the drainage system, lymphatic drainage system of the breast. You have learned that, right? Correct? Okay.
Yes, doctor.
All right. Okay. Oh dear. Where am I? Sorry. I want to go to. Okay. I'll just share with you a few cases, how a breast cancer patient can present to you. Okay, a 30-year-old lady present with a sudden or first time onset of profuse bleeding, with a lot of bleeding from the nipple, and not notice whether there was a mass or not in that affected breast. Bleeding a lot that is really stained the clothing. And immediate mammogram. You know mammogram kan? Heard of mammogram? It's a radiological examination of the breast. We call it mammogram. Okay, an immediate mammogram was arranged and it shows that the entire right breast has got some lesion going on, filling up the whole breast. That's how huge the lesion was. The lesion, the growth. So they attempted to do a fine needle aspiration cytology, FNAC. Have you heard about FNAC before?
Yes, fine needle aspiration.
Has anyone talked to you about this procedure?
For thyroid disorders.
Okay, you have learned this. Okay. Yeah. Anyway, this is a procedure which I'll just show a picture later on, later part of the lecture, how it's done. It's quite a simple procedure where you suck out sample cell from the tumor and try to get a presumptive diagnosis, a guide as to what this lesion is. It benign or is it malignant? Is it just inflammation? Is it pus or whatever? So that was done for this patient, and it actually just because it was so bloody, was so vascular. Oh dear. Hello.
Yes, doctor. Yes, doctor.
Tak buka langsung.
They can hear. I think they can hear me, but I can't
Can they
see.
see you?
Huh?
Can
No,
they see
I
you?
cannot see that.
Doctor, can you
Yeah,
hear?
hold on.
All right.
Can you see the screen?
Yes, we can.
Wait, my screen went blank.
Try sharing and unsharing and then sharing again.
Yeah, but the thing is my screen is blank. Kejap,
Or completely.
I can't see anything on my screen. Hold on, I restart,
All right, doctor.
Okay, doctor.
Restart. Three. Hello? Hello?
Hello, doctor. Can hear
Yes,
you.
doctor. We can hear you.
Boleh?
Boleh, doctor. But we
Okay,
can't see your
okay,
screen yet.
Boleh, Doktor.
Sorry for the glitch ya. Jap. Right, where were we? The first case ya?
Doctor, we can't see your screen.
Kas? Alamak, tak boleh nampak skrin dah pula.
Not yet, doctor.
Wait. Can you?
Okay.
Yeah, yes, doctor.
Nampak dah?
Nampak.
Now okay?
Yes, okay.
Okay, so sorry about that. Tak apalah. We have time. We're supposed to finish about 1, right?
Yes, Prof.
Okay, so we have time. It's okay. So coming back to our first case just now, a youngish lady, a 32-year-old, presented with just bleeding from the nipple without complaint of a mass. But on examination, it was found that actually the whole right breast has got a lesion that is very, very vascular and bleeding. So because the FNAC that was done cannot 100% confirm what is the whole lesion, they proceed to do a removal, which is a total mastectomy. They remove the whole breast. Then that's the time when they found actually the mass is quite spread out all over the breast, and the diagnosis came as papillary DCIS. DCIS stands for ductal carcinoma in situ. Remember the term CIS that you learned earlier? It's really still an early malignant lesion. The basement membrane is not breached yet. Hello? Am I okay?
Someone unmuted
Yes.
by accident.
Oh, can you can hear me?
Yes,
Yeah,
yes.
can.
Yes, doctor.
Okay. Sorry for the interruption. So what I'm saying is this is a young, quite young lady presented with not with a mass, with bleeding, and what we found was a huge lesion in the breast, and the diagnosis turned out to be DCIS, which is ductal carcinoma in situ, an early stage of breast cancer. So the good thing is it's still an early cancer, even though it occupies a big area of the breast. Yeah. So prognosis is quite good. Patient had operation, no chemotherapy, no radiotherapy, no other treatment, but survived well without any further recurrence of the tumor. Right? Okay. Case 2 is an elderly lady who complained of non-specific symptom, loss of appetite, loss of weight, quite drastic, and quite a lot of weight was lost, and had not complained of any breast lump because it's painless. Yeah. Take note, majority of our breast cancer actually complain of a lump in the breast which is not painful.
Prof, your voice is cut off.
Doctor, we can't hear you anymore.
Hello, doctor. Can you hear us?
Yeah. Can you
Okay.
hear me? Can you
Yeah.
hear me?
Yeah, you stopped
Yeah.
at Stephen.
Yeah, okay. I thought I don't hear any response, so I thought you can hear me. Heard of the moxifan? Ada?
No.
Not yet. Okay, never mind. This is actually a specific drugs treating some cases of ductal carcinoma. We'll talk about this in a while. Okay, I'm just showing you example of cases how they present in variable ways. And patient was well and actually did not pass away because of the disease or because of old age of other illnesses. Okay, the next case is like this is a more typical age group, 40-year-old, complaint of breast lump, as you all have mentioned earlier. But this patient had also history of papillary carcinoma of the thyroid when she was much younger. And it was treated and well. Now she came up with another cancer. Okay. And again, this was through cut biopsy was done. And it shows a ductal carcinoma. Excuse me ya, sekejap ya. Sorry, this is the downside of working from home, the distraction. There's a lot of noise outside. Okay, right, this patient had quite a standard practice of treatment for ductal carcinoma. After the mastectomy, removal of breast, she had chemotherapy, radiotherapy, and is a good prognostic tumor, and she's well, right, very long after the first. No recurrence, no further complaint of the breast. A similar age patient, again complained of the same lump in the breast, same histology diagnosis, ductal carcinoma. By now you should know all the three cases had ductal carcinoma compared to the first one, which is slightly different. Ductal carcinoma is very common. Again, patient had mastectomy, radiotherapy, chemotherapy, and well, but about a year after that, she complained of lump of the other breast. So this is a bilateral cancer of the breast. So it was a confirmed recurrent and she had another, the same thing, mastectomy, chemotherapy, radiotherapy. But the good thing is a good tumor in the sense that she is well and alive long after the first diagnosis. Case 5 is slightly different presentation. Around the same age group. This is actually my colleague. We were training together and this is another presentation by patient, a very vague lump. On examination, you cannot feel a definite lump like the other cases. It just look lumpy. Patient doesn't have any other complaint. No nipple discharge, no skin changes. And actually diagnosis took a while because we couldn't get a tissue to diagnose. Biopsy, FNAC was attempted but does not show any tumor cells. And I think after third attempt or something like that, we managed to get the cells out. It was diagnosed as lobular carcinoma. You notice this is lobular. The other three I talked about was ductal. Yeah, take note of that. The behavior is quite different. So this lobular carcinoma was treated the same way, had mastectomy, chemotherapy, radiotherapy. She was well until she developed a recurrent on the other side of the breast. And unfortunately for her, not long after that, she had secondaries and she died of the disease. So I'm just illustrating to you the different ways a breast carcinoma can present to you when you are practicing as for example, a surgeon, right? Okay, the issues with breast CA is actually common globally, worldwide. It still present as one of the highest cancer mortality despite we having mammography as a screening program practiced quite widely, and also quite good regime of chemotherapy for those patients who actually responded. Why this is the issue is no one breast cancer patient is the same as another. If you have 10 breast cancer patients, they are all quite different. They behave differently, the behavior, the appearance and the growth rate, they're very variable. So it's not as straightforward as having one disease, clear-cut features ABC, treatment ABC is not like that. And mortality is quite high because of metastasis in some of these patients. So in terms of pathology or metabolically, the behavior of the tumor cells are different. In one tumor, you can find different pathway. I will not elaborate to you all these little details, but just to illustrate to you that breast cancer is not that easy to treat. Not that straightforward. And some cases are resistant to the standard chemotherapy regime. So it's really a complex issue, not as simple. And the disease is very, very common. Mostly in developed countries. We don't know why, but it is actually very rampant worldwide. Hello, are you okay so far?
Yeah, we're okay.
Yes, doctor.
Any questions? No, okay. This is a revision. I'm sure you have learned this. What ductal breast lining are. They are actually modified sweat glands. They're called TDLU, terminated duct lobular unit. They are aligned from outside, from squamous. As they go in, you have stratified columnar, cuboidal, and these are the terminal ductal units. They are really small, in groups like that. Clusters, and these are all the supporting stroma. The thing is why this is actually under reproductive system, because breasts are actually similar to your the female genital tract. They actually respond to all the hormones. I think you have covered this in physiology. They do respond to estrogen, progesterone. So that's why sometimes patients complain of fullness or discomfort in the breast according to the menstrual cycle. They also show changes due to pregnancy as well as menopause. These are all hormone related. Just another view. This is if you cut cross section. This is what you get. Cross section of the breast lobules or lobes. Just to show you. Remember, just now you said some patient complain of axillary mass. That is because whatever tumor that was growing there can actually spread to the lymphatic, to the axillary lymph node or all this supraclavicular internal membrane node. So these are the lymph nodes that the surgeon will look at when they had to do a mastectomy for a patient with breast cancer. Okay, before we go into breast cancer or breast tumors itself, I'll just discuss your overview. Disease of the breast that you can see or you come across. We'll not talk in details about all this, congenital lesion, inflammatory. Just bear in mind that some of this lesion can mimic, can confuse you as attending doctor to a case with carcinoma of the breast. These notes I put at the end of the lecture. You can take a look at it later. But I will just discuss a bit on fibrocystic disease. Why it's important? Because actually some of cases of the fibrocystic disease actually can predispose or can have a pre-malignant focus that can give rise to a malignant or cancer of the breast, right? This is just to show you a picture and where you will find, we will discuss about fibroadenoma, cystic disease, the cancers, okay, Paget's disease, Phyllodes tumor, right? Okay. Just to share, okay, if a patient comes to you, complain breast lump, and you take a biopsy, these are the chances or the expected finding in about 10%, only 10% will turn out to be cancerous. A similar percentage, the benign tumor called fibroadenoma. In almost half of the patient, you will have this diagnosis given by the lab. A patient comes with a breast lump, you take a biopsy, the biopsy is sent to the lab, and we pathologists in the lab will give you a diagnosis of fibrocystic change or fibrocystic disease. Same thing, fibrocystic disease. That's in a big chunk percentage of patient. So learn to understand what this disease means and what is the importance that I will discuss in a while. In the other half of patient, sometimes we couldn't find anything. About 30%, 1/3 of patient, we could not find a definite pathology in the tissue that's sent to us. Of course, a small percentage will reveal the inflammatory lesions that I listed earlier. Okay. Okay, before we go to the cancer, what are the benign tumors of the breast? There are a few. The most common is fibroadenoma. Okay, as the name imply fibro is a lot of fibrous tissue. The connective tissue is there. Adenoma is proliferation of glands, but it is benign. It's very, very common. If you work in HKL, which I have worked there for the last 30 years. Okay, if you work in the pathology lab, the resected breast lump sent to you that turned out to be fibroma is like you get it every other day. That's how common. It's very common. Okay, it's proliferation of both glands and stroma. This is the common age presentation. Once they are reproductive age, that means once they have attained menarche. So sometimes patients come as young as teenage, but usual age is between 20 and 30. Common presentation is single lump, which is painless, no pain, small, very, very mobile. Sometimes it's more than single, one or two, but usually single. It's very well defined. And size-wise is about very small, 1, 2, 3 cm when they present to us, but some cases they can be as big, as huge as 15 cm. We've seen, but very rare. Commonly they're about 2, 3 cm size. Okay, this is what you see histologically. Remember, fibroadenoma is not malignant. It does not turn malignant. Remember that. It's totally benign. If patient comes back with another mass, it might be another fibroadenoma. Let's say one resected, and then a few years later she had another lump. It could be, occur, but it's not actually pregnant. It does not recur. It's just another growth of the same name, fibroadenoma. So this is how it look like actually when you resect. It's very simple. Usually it's quite superficial. You make an incision and it come out quite nicely because it has got a nice capsule around it. Like this, very nice and easily taken out, separated from the rest of the breast. A typical appearance of fibroadenoma. And as expected, fibrous tissue, there's a lot of fibrous tissue, so much so sometimes it compressed the proliferating glands. The tubules and the glands are actually proliferating, but because there's so much supporting tissue, it also get compressed into such compressed structures. These are actually glands like this, cross section, but because they got compressed, they appear elongated. All right. This is the other benign tumors that you should be aware of. It's called phylloides tumor. Phylloides tumor, right? What is it actually? It's basically quite similar to fibroadenoma, but there's so much more stromal tissue because there's a lot of stromal cells that it grows much bigger. Usually they're very large, 10 to 50 cm size, and they grow into a slit-like. I show you a picture what this means. Leaf-like and slit-like structures, because of the excessive and abundant stromal tissue, right? So when you have such a tumor, we always in the lab as pathologists we look at the cells carefully, because we have to look for this which could be there, but in general they behave like a benign tumor. The only thing is when clinically, if the lesion is not removed totally and the patient complains of rapid increase in size, be careful. It's time actually you should take it out because malignant transformation can occur. So by the time this happens, when you take out the tissue, the so-called capsule that you see in fibroadenoma seen here is now already invaded, can be invaded by the tumor cell. So that's not good. So the thing with this malignant ones, the malignant counterpart of phylloides, they can recur even though they're localized. They hardly metastasize, but they can locally recur. So just be aware. Majority of them are benign. Small percentage can turn malignant. When they are malignant, they can metastasize. Of course, because you know the name tumor here, we don't call them adenoma. We don't call them adenoma because there's such a thing, such a situation when you see this tumor is not possible to determine whether they're benign or malignant. A small percentage. This is when we call borderline, but this denote that the patient need to be properly follow up. All right. Overall, benign phylloides tumor is not common, but know the nature of the lesion. They are such, benign, rarely malignant. In between, sometimes it's difficult to determine. We call it borderline. All right. The thing with this phyllodes, characteristically, they present very huge mass of the breast, such as this. Can you imagine how many times more here? Almost 10 times. So histologically, as I said, similar to fibroadenoma, a lot more stroma, rapid enlargement, so they present like this. Histologically, they look like this. This is what I meant just now, the leaf-like, cleft-like. So there's abundant stroma here. The glands compress much more like this. Okay, but the lining are usually still maintain the benign nature. They're not diplomorphic. Like this, there's a lot of cells in the stroma, and the cells can be very, very big and frightening. But as long as the capsule is intact, we call it benign phyllodes. Okay. The third benign tumors is intraductal papilloma, not as common as fibroadenoma. Is benign, usually is single and very smallish. Usually very, very small. The thing that frightens the patient is they present with bloody nipple discharge without an actual lump that they notice. So, and the lesion is usually subareolar, just beneath the nipple. So sometimes the nipple can present with retraction. So that can be confused with a carcinoma, actually, just like what you mentioned earlier. You said nipple retraction, sometimes you see this because it's actually situated underneath the nipple. But histologically, this is what we see, just a proliferation of the cells forming papillary structures. Okay, from pathology point of view, it's a challenge to us because intraductal papillary carcinoma can look similar. So for your sake, at your level, I think you just know that this is actually mostly a benign tumor, benign intraductal papilloma. So it's a smallish lesion. There's about 2 cm, and it's actually covered nicely by a border, no invasion. But the inside, the lesion itself is finger-like papillary. That's why we call it intraductal papilloma. Okay, that's papilloma. This is the next group of disease that make up a big chunk of a big percentage of patients coming with breast lump, fibrocystic change or fibrocystic disease. Very, very common among reproductive age group 20 to 40s. Alright, and it could be due to hormone influence because this is when the most reproductive age, the peak. Histologically or pathologically, the appearance of this lesion is not as straightforward as fibroadenoma that described just now. Fibroadenoma is proliferation of stroma and epithelium. In phyllodes, just now we see more stromal proliferation, but in fibrocystic change, there's very great spectrum, a mixture of changes. So we try to summarize or simplify this into 2 types for prognosis purposes. There's one non-proliferative change in which is the stroma that's got a lot of fibrosis and very little epithelial component. But characteristic of this group is the cyst formation. Hello? Hello?
Hello, doctor. Your voice
can you hear me?
I think it's okay. Yeah.
Is it okay?
Yes, doctor.
Yeah,
So far, okay, all right, okay. Okay, fibrocystic change, 2 groups, okay, 2 categories sort of, non-proliferative in which there's not much cellular changes there. The proliferative ones, the more important one, there are proliferation of epithelium and glands. I show you some pictures in a while. And this is the part that you have to take note.
This is breaking again.
Can't hear me? Okay?
Yes, we can hear you, doctor.
Okay, clear.
Clear.
Did I hear someone say I'm breaking up?
I think it's the Wi-Fi of the person.
Oh, okay. So, okay, I'm okay? I'm clear to you?
Yeah, okay, doctor.
Okay.
Yes.
Okay. Proliferative morphology or proliferative changes in this fibrocystic disease are the one that you should take note. So whenever you have a patient coming to your breast lump and you're not sure whether it's benign or malignant, you take a biopsy of the lesion and you have this diagnosis, fibrocystic change. Please take note of the report. What is highlighted there? when it mentioned there is epithelial hyperplasia, be careful. You have to look further than that because there's a risk of this patient turning malignant or cancerous later on. So you have to follow up this patient properly. Okay. Yeah, this is what I tried to show you. An example of fibrocystic disease. A resection was done and there's actually a cyst at the center there. Can you see that? A swelling filled with some fluid. So this is what causes cyst. On microscopy or histology, this is what we see. There's a lot of fibrous tissue. You know, the pinkish area are the proliferation of stromal tissue. Look at this glands, proliferating glands. As compared to your normal histology just now, you see small clusters of ducts and glands. Now they are all over the place. Not just that, some of the ducts are dilated like this. You see, there's some content there, some fluid, some content, serous content, or just mucoid content. But the glands are dilated like this, Some are just proliferating around. Sorry. Okay, so this is the ductular proliferation, glandular proliferation in fibrocystic disease. Okay, this is the feature that I said you all must look out for, the presence of epithelial hyperplasia. It simply means those glands that I show you proliferating, they are lined by cells which are multi-layered. Okay, so much so there's so much of them, they protrude, they fill up the lumen and obliterating the lumen. I show you a picture in a while. Okay, so what is appreciated by the pathologist in the lab and reported to the clinician treating the patient is, what is the hyperplasia like? What are these cells looking at you? How did they appear? Is there atypical abnormality in terms of the cell appearance or the architecture of the glands, that they are that present in this lesion? So those report that says there's atypical cellular appearance, this you really have to take note, because these cases are represent the pre-malignant group. So you have to treat this more aggressively, like total resection of the mass and further follow-up and doing all other investigation like mammogram there, to detect whether in that particular breast is there any other changes nearby. Is there a cancerous lesion, right? Okay, this is to illustrate to you. This glands is actually a bit dilated, but can you see the single lining there? Can?
Can, doctor.
Yes, doctor.
Okay. So this is more like resemble the normal glands. The lining cells are single, but they can proliferate to this in the sense that they become so much more. You look at this particular gland, duct is totally filled up by the proliferation of the cells. Can you see this dark stains area? Boleh nampak tak?
Can, doctor.
Can you see this? What do you think this is?
Calcification.
Yeah, right. And that's not a good sign, That's not a good sign. So this is epithelial hyperplasia in a fibrocystic disease. This is what they can look like. They're so proliferative, they completely fill up or block the duct totally. Okay, another case where this whole duct lined by proliferation of gland. Not just that, if you can appreciate the morphology of the cells, they are very pleomorphic. They are large, they're quite dark, and there's prominent nucleoli. So this is not a good sign. This is atypical hyperplasia. So when you have patient with fibrocystic disease and this is reported, this is seen in the microscopy, this is serious. Okay, you have to take a look at the patient more closely and follow up accordingly. All right. Okay, so in summary, why I highlight so much on this disease is common and clinically significant because they also present like a mass. So you have to differentiate whether this is just fibrocystic disease, the benign one, and differentiate from carcinoma. The other thing is the epithelial component present can decide whether this patient has got a chance to become cancerous in the near future, right? Okay, these are just clinical when the clinician think is benign or malignant, bilateral, multiple and all that. Okay, right. What else? So actually pathologically we can actually try to give an idea, an estimate to the case. How much is this case will have a chance to become to develop a cancer. Okay, if the report says like this, just apocrine, metaplasia, you look at the report, if they just say apocrine, hyperplasia, mild, not to worry so much. But when the hyperplasia is more severe, more florid, then the risk is higher. Of course, when there's atypical hyperplasia, just like what we discussed just now, the risk is much higher and definitely multiplied when, yes, the patient had a family history, sister, mother, auntie, blood relation who has got history. This patient deserve more close attention. All right, is that okay with you all? Okay, faham fibrosis change?
Doctor.
This one can you see not?
Can, Doctor.
Cute tak kucing ni? Siapa ada kucing kat sini? Who has cats? How many pair of tits or breasts here? 1, 2, 3, 4. So I think gambar ni tak berapa betul lah. I think cats ada 3 pairs saja kot. Anyway, just a short break lah before we go into cancer. Anyone wants a break? Pukul apa dah? Shall we just go on and then you can have a long break for lunch?
Sure, Doctor.
Boleh ya? Okay. So we will now go. Boleh ya? Boleh. Kita proceed je ya. The breast cancers, why is so important? I have mentioned to you how they present and the occurrence, right? How many of you in this class? 120 ya? Saya tak ingat lah this number you all.
121.
100?
121.
121.
121 to be exact. How many girls are here? How many girls?
So many, Doctor.
Majority girls ya?
Yeah.
But I cannot see you all from the name pun agak-agak je. How many girls in the class?
About 60%.
60%
60
boys 40% lah.
About that.
So boys are the minority, is it?
Yeah.
Anyway, just asking. Okay, out of 60% of you, 10% will have carcinoma of the breast. Is that frightening? Yes or no?
Yes, Doctor.
But the good thing is, I know many breast cancer patients who actually survive. I've got a close friend who had cancer of the breast, and somehow because she had chemo, radio and all that, she developed second malignancy due to the treatment. Can you believe? She had she had AML, myeloblastic leukemia, but she was treated with, I think she had a sibling who actually donated the bone marrow, and somehow she survived. She's well and alive and kicking despite being older than me. Can you believe that? So yeah, be scared. You can develop carcinoma of the breast, but the good thing is majority patients survive actually if they receive early treatment, early diagnosis, early treatment. Mind you, the 5 cases that I talked to you about, the last case was a colleague of our colleague, a medical colleague. The others are my family. The first case is my sister. The second case is my grandmother. The third and fourth case is actually my cousins. So it runs in the family. So yeah, having said that, maybe you ask me, have I gone for screening? My risk is quite high, but okay. The other thing is, you know BRCA? You know BRCA gene? Heard of the gene? You belajar tak dalam modul apa you belajar gene BRCA?
We've heard of it, Doctor. It's associated with breast cancer, right?
And in some countries, the more developed countries, they do screening for BRCA, especially in high-risk groups. But we are yet to offer such services in Malaysia lah. Otherwise, I've gone for one. Do you know the actress Angelina Jolie? Kenal tak?
Yes, doctor. Kenal.
You know what she did?
No, doctor.
Yes.
No. Yeah, yes. What did she do?
I think she removed
Mm.
her breast and uterus.
Yes. What else did she remove?
I think ovaries too, I'm not sure.
Sorry?
I think she removed her whole uterus and ovaries with the
Yeah, because I think her mom died of ovarian CA at a young age, and she did screening for herself. So she was found to be carrying BRCA, and she opted for preventive measures. You know, that's quite drastic. I don't know we allow such procedures in Malaysia. But yeah, she removed her genital organs because of the risk of developing high risk. I think they actually measure her risk is very, very high. So she said, why not? She just remove and spare her the illness. Anyway, okay. So those are the evolution of progress of development in epidemiology and pathology of breast cancer and treatment. And to the point that patient have that option, you know, removal to prevent the cancer occurring. Anyway, it's that common. I think the latest statistic has now is 1 out of 8, if I'm not mistaken. This is some quite old statistic, 1 of 10. So be careful, girls. You know BSE, breast self-examination. Tak? Pernah dengar tak?
Pernah, doctor.
You know how to do it? Learn how to do it because it's the simplest and doable screening program of the breast for breast cancer. Yeah, the patient could do it themselves. They examine the breast at the same cycle of the menses, just to detect any changes or any lump. And actually, quite I think about majority of cases actually the patient actually present lump that is self-discovered. They discover themselves, so they come to us. So it's that easy, right? Of course, you have to look at other associated risk factors. Anyway, this is the other peculiar presentation of cancer of the breast. They present with painless mass, just like my grandmother. The mass was there growing. And of course, we never examined her, and we asked, the mass is quite big. Why did you complain? It's painless. Seriously, 99% actually complain of painless breast lump. So take note. The painful one are not to worry about because those are inflammatory and treatable by inflammatory drugs and antibiotics and such. But the painless one are the one that is most likely cancerous. All right, risk factors. The older you are, how old are you, girls? You must be 21, correct? This year? Betul tak?
I think for some, yes, doctor.
The youngest patient I have seen cancer of the breast is 19 years old. Okay, it's very rare. I think my whole life that the only one, the young one. Usually they are 30s, 40s. Yeah. So before age of 20, they are rare. Of course, as we discussed earlier, family history, history of BRCA, other markers there. Reproductive age group which is prolonged, like early menarche, late menopause. This is postulated because the exposure, long exposure to the hormones. Okay, parity, when patient does not have any children, also associated with late first child, like more than 30-year-old, that's your first child, chances you're at greater risk. Okay, it's all related to hormonal exposure. Okay, and as I have discussed at length, fibrocystic disease or fibrosis change associated with atypical hyperplasia. And a fourth patient who had one breast cancer diagnosed in one breast, they are at higher risk to develop it in another one. And another carcinoma associated with cancer breast is cancer endometrium, again hormonal related. Yeah, so know these risk factors. This is very important. You must know this. Your favorite exam question: risk factors carcinoma breast. Take note. Right. Of course, there are other established factors, obesity, all this they're not really clear cut how it's actually related or giving rise to carcinoma breast. So all in all, pathogenesis could be there is an interplay between all the different risk factors that we discussed just now. Okay, genetics, hormonal influence, environmental factors. Okay, going into pathology, all right. Carcinoma of the breast clinically somehow is more common to the left. I don't know why. We don't know why. Upper outer quadrant also we're not sure why. Okay, as I said, painless lump, but they can have all these other that you also have mentioned. Nipple retraction, skin changes, orange peel appearance. Have you heard of this?
Yes.
Why is it called orange peel appearance? Can you pronounce that in bracket? How you pronounce that? Can someone try? That is a French word. Anyone knows French here? Anyone can speak French here? No one? Tak ada? No response. Hello, hello.
Yeah.
Anyone can speak French? Try to pronounce that.
No,
Tak apa, just try to pronounce. I had difficulty pronouncing this up to this day.
Pew the orange.
That's
Like
how
a
we like to
pole
pronounce it
orange.
because it
Pole.
sound pew the orange. Pew the orange
Pew
is like
the
macam
orange.
bunyi BM kan? But actually it's supposed to pronounce, I don't think I pronounce correctly also lah. Pew the orange.
Doctor, peau d'orange.
Oh,
She knows
someone
French.
could pronounce.
Yeah,
Who?
Sarah.
You learn French.
No,
yeah,
she's from Algeria.
Doctor speaking.
Anyway, it actually arise. Why the name is because it really look like orange skin. You know the orange that we eat, buah tu. It look like that exactly lah, almost. Anyway, sometimes patient present with physician, so skin changes because it's stuck to the underlying structures. Yeah. And of course, if they do an ultrasound or radiologic examination mammogram, calcification is a big clue. Usually it's there, presenting as a calcification. Not sure whether you can you appreciate there's a smallish irregular lesion here, and there's some specks, dark ones are the calcification. So this is a very suspicious lesion, irregular mass.
doctor.
This is the pew de orange. Can I pronounce it? See the changes like orange skin, hardened, irregular. Okay. Usually this is because it's actually edematous tissue. The lymphatic system or lymphatic channels underneath the skin. This is the skin. Okay, this is part of your breast. And these are the lymphatic system which are clogged, obstructed by the tumor cells. So the drainage is poor. So the edema will develop in that area. So that give rise to that skin changes.
Doctor?
Sorry?
Doctor, is there a specific reason as to why it's more common in the left breast?
I just said earlier, I don't know, and we don't know. But somehow statistically is more common on the left side. So maybe you should examine your left breast more often lah. I don't know, really. That is to be explored further. Anyway, this is, sorry, I don't have a better picture. This is actually a cross section of breast tissue. Breast tissue is very fatty, a lot of fat. So you see, when you cut, it's actually very greasy. A lot of fatty tissue, yellowish in color. So there's a whitish irregular lesion here. So this is from gross we can tell this is actually most likely a carcinoma, okay, compared to a more defined lesion, fibrinoderma like this, okay, right? So what about carcinoma of the breast that you should know? Because basically, again, remember when we talk about your cancer of the cervix, you have the CIN, kan? The dysplasia, and then you have the invasive. So the breast is very similar. You have a lesion where it's not invasive, right? We call it non-invasive, which can be of two types, ductal and lobular. Ductal is more common. Lobular is hardly seen. Of course, the invasive group. So I will give details of this in a while. DCIS, ductal carcinoma in situ. Okay, these are just the histologic pattern. What you see on histology, solid. These are the description in the appearance of the glands that is malignant. Okay, they can also have calcification. Okay, what's good about DCIS, Dr. Kasuma 1 is actually prognosis very excellent. Just like the first case I illustrated to you, case 1 just now, it was actually also a DCIS. Only that was not ductal, that was papillary, but it's early stage DCIS, and prognosis is excellent if you actually treat early and remove the whole lesion. Yeah, very good prognosis. You don't have to do chemotherapy, radiotherapy. You just follow up the patient. They don't usually recur. A very, very good survival. You're almost like back to the normal population. Right? Okay, this is one example of histology where the cells are still within confined basement membrane of the ducts, but the glands are very pleomorphic. There's necrosis. This area at the center is to show you necrosis, which means the center, the cells does not get enough blood supply, so they die. This is not a good thing. In fibrocystic disease, fibroadenoma, you don't see necrosis. When you see necrosis, it's not good sign. Yeah. So this is what I see in DCIS of the breast. Okay, done with the non-invasive, we go into the invasive, which is the main bulk of your cancer of the breast patient. There are actually quite a number of types. I just list to you the more common ones. Actually, the list is much longer, but it's not for you to worry at this stage. Okay, right? The most common one is invasive ductal carcinoma. Second, invasive lobular. All these 3, 4, 5, 6, 7, they are quite rare, but they actually have a better prognosis. So when you have a patient diagnosed with cancer of the breast, look at the report properly. What is the histologic type? Okay. If they turn out to be one of these, the prognosis are actually better. Okay, I show you a picture in a while why they are different here. Okay, this is the invasive ductal carcinoma, which makes up the majority, about 70-80% of patients, typical. You see ducts. You can see. Can you see the duct structure here? It's a bit dilated, but it's a duct here. Okay. Of course, the others are just not forming duct so well. Okay. Why I'm talking about this, we will talk about grading later on. Okay, the most common types, okay, is how they present. They present with a mass, quite well demarcated, but hard, irregular. Gritty sensation is when you cut the tissue, you know, when the specimen is sent to the lab and you cut the for sampling, you get a gritty sensation because of calcification. Yeah, okay. Usual signs about this size, okay, 2 cm. Size of lesion is very important to take note because that has a weightage on prognosis or outcome for the patient, all right? And microscopically, you see, when I said undifferentiated pleomorphic, they are actually, what I mean is malignant cells. They are pleomorphic, they are abnormal looking, all right? Okay, this is the second type, which is less common, about 10% of cases. It's quite characteristic because this lobular carcinoma, the cells don't actually form glands. They just arrange in single file. We call it Indian filing. That refers to Indian soldier filing. I'm not sure who actually developed this term, but when we describe this Indian filing or single filing, it actually point to lobular carcinoma because behavior is quite different from ductal. Lobular is quite different. Why? They tend to be affecting the both sides. Remember case 5 I talked to you earlier, my earlier slide, case number 5, my colleague, medical colleague, she had a bilateral lesion and multifocal. So that is a characteristic behavior of lobular carcinoma. And they present quite early with metastasis. So prognosis is not good. Okay, this is the third time. It's not common, but they have a characteristic appearance as the name implies, mucinous. Mucinous means there's a lot of mucin. You know what mucin means? Is that secretion which is sticky coming from glands. Okay, so one type of breast cancer can actually present with this feature. So sometimes you have a mass of the breast within with this diagnosis. You cut the tissue, is very difficult to process because a lot of mucus. They're very gelatinous, sticky, very messy to process. So the cells are there, malignant, but they float around in abundant mucinous material. The good thing about this cancer is this type is good prognosis. Yeah. Similarly, that's tubular. Medullary. Medullary is specific because the cells pleomorphic, yes, but they are accompanied by numerous lymphocytes. Somehow, this is characteristic of this breast cancer. They tend to be big in size. The good thing is the prognosis is better than ductal. Yeah. Okay. This is the tubular one, which is this is very good prognosis. The tumor actually characteristic present in old age. All right, and they have very good prognosis because the glands nice looking actually, but they are invasive. That's why we call it carcinoma, and they got the the best prognosis among the cancer of the breast. All right, so just one more. I will not talk about all the rarer ones. Why I highlight this also as part of cancer of the breast is because this type of patient, Paget's disease of the breast, they don't usually present with a lump. They present with skin lesion. So if you are a GP or an outpatient department, seeing a lady complaining of eczematous skin lesion of the breast, be careful. You don't simply treat them as eczema. You give steroid and that off you go. Cannot. You have to explore further investigate, because Paget's disease present with skin lesion, usually they are associated with some underlying ductal carcinoma nearby, even though the patient does not present with any lump. Yeah. Okay, get that? I hope you get this clear in your mind. You have to carry this information right through your career. Okay, because some cases we miss. Doctor shrug off skin lesion of the breast as just some eczema or some skin reaction without actually checking further. So don't forget this point. This one you must take home for good. Okay, this is what I'm trying to show you. Just some skin lesion, usually around the nipple, areola region, like here. This is more advanced, So be careful about Paget's disease of the breast, yeah. All right. Yeah, we've done with all the histologic type and the different prognosis attached to different histologic diagnosis. Next that you must look out for in patient that is diagnosed with cancer breast is the grading. One breast cancer A, another patient with breast cancer B, they are looking very different. They never look the same. So how do you differentiate A is better than B is you have to do grading of the tumor cells. So those pictures that I showed you that represent the cancer, you have to do three things. You have to try to quantitate. Is there a lot of gland formation? What about the nucleus appearance, the cells itself? And what about mitotic figures? Is it there or not? So based on these three features of the tumor cells, you give them point. If there are good tubules formation, 1. 3 is the other way, not so well formation. Similarly with nucleus and mitotic figures, I show you a picture in a while for you to understand this concept. But this grading you must know. Ini wajib tahu, Okay. When I say whatever I stress, itu akan keluar soalan dalam exam. Okay. Not just keluar dalam exam, but things that you must take home for you to remember and practice once you are a doctor. You get me, everyone? Okay. Breast cancer is very important. You must know a lot, but those that are highlighted, you must know very well. So at the end of this grading that is done microscopically, your patient with cancer of the breast will have a report. Breast, I don't have a picture to show you report. Breast cancer, the type will be intraductal, ductal carcinoma, lobular, whatever, and then grade. Okay, the grading will be there. Is it grade 1 or 2 or 3 based on this assessment system, Bloom and Richardson system. You must know this system, yeah? Okay, this actually summarizes how we pathologists do the grading. With regard to tubule formation, if they're very, can you see the glands there? Yeah? Widespread, you give 1. When it's not so well seen, 2. And when it's more solid like this, you give 3. That is in terms of tubule or glandular formation. Then look at the cells. How bad looking are they or ugly looking? If they're really quite uniform, 1, They started to be bigger, abnormal, 2. When they're very, very abnormal, is 3. Next is you do the mitotic count. Okay, very few, grade 1, 2 is intermediate, and 3 is when the mitosis is all over the tumor cells. Okay, I hope you get this clear. Eh? So this is an example of a grade 1. Can you see then? You see the tubules, the duct formation, the gland is still there, kan? Okay, rounded with lumen, so that's well seen quite throughout, and the nucleus are still more or less resembling each other, not so ugly looking. Okay, mitosis, maybe 1 or 2. So this is grade 1. What about grade 2? Okay, grade 2, the gland formation not so clear. The cells are looking bigger, right? And mitosis started to be seen around. Okay, of course not as plentiful, but 1 or 2 around. Okay, of course grade 3 is the highest grade, the most severe. There's hardly any gland formation. The cells, the nucleus are very, very pleomorphic, and mitosis are usually plentiful. They are all over the place, right? So this is grade 3, right? Right, okay, that's grading, very important, you must know that. How about the spread of cancer of breast? As in other malignant tumors, they spread either lymphatic or by blood. Actually, in about almost half of the patient that we diagnose in the lab, they usually will have that, will already have a lymph node involvement. Hematogenous is only in the advanced cases where they already metastasize to liver, lungs, bones and brain. Those are the 4 common metastatic site for breast cancer. Okay, one more thing that you have to know about cancer of the breast, apart from knowing is cancer of the breast. What is the type? Ductal, lobular, mucinous, blah blah blah. What is the grading? Is it grade 1, 2, 3? The next thing you should know about the carcinoma of the breast patient that you're dealing with is the prognosis. How do I tell Mrs. M, your prognosis is like this, like this. Your expectation, survival rate is, survival rate is how long? 1 month, 1 year, 10 years? You know, patient will ask you such questions when you are treating them. Be sensitive, okay? These are the things that patient will ask you. And in order to answer their queries, you have to have all this knowledge. Yeah, you must know the breast cancer that you are looking at in the patient, in terms of grading, in terms of all this that I've listed here. Okay, does the patient have any lymph node involvement? Okay, lymph node does not just mean a lymph node. Why I put here first? Because it's one of the most important prognostic factor in a patient with cancer of breast. Unfortunately, almost half patients have got lymph node. Sometimes they don't present with a enlarged lymph node per se, like axillary, intermammary, but we can actually detect them microscopically, which means pathologists in the lab will cut the tissue, and we found that some of the tumors are already going into the lymphatic vessels or blood vessel microscopically, meaning it's not seen by the surgeon, not seen by the clinician, but it's seen in the lab under the microscope. So we will report this, we will highlight this, because this will determine the prognosis of the patient. You get me? Okay. The other thing is size. Less than cm size, patient has got better prognosis compared to 5 cm, 6 cm, or even bigger. Histologic type, we have talked about it earlier. The other thing, okay, estrogen progesterone receptor. This particular prognostic factor, this is done in the lab. We detect these receptors in the breast tissue, breast cancer itself. We tested this and we will report whether it's positive or not. If it's positive, it's good, because then patient can be treated with tamoxifen, and the tamoxifen will kill off the cancer cells. If it's negative, bad news for the patient. They cannot receive tamoxifen. Okay, you understand that? The other thing is proliferative rate, which we actually also do in the lab. It's not as important, but it indicates proliferative rate, meaning these are all the markers where we do, let's say, proliferative very high, 100%. That is not good, because that indicates that the patient is really fast. The cancer cells are fast growing, which is not good to the patient. All right. Next is, okay, presence of all these markers, HER2 or the other name is CERP, okay. Presence of this is detected again in the lab, in the tissue, is associated with poorer prognosis. It used to carry bad prognosis, but people have come up with this drug, Herceptin. So if patient had the opportunity to receive this treatment, they can respond. Unfortunately, it's still expensive. So so there's cost to be thought of in treatment of patient with this particular oncogene. All right. Of course, pregnancy. Yeah, we had patient who was pregnant and had been diagnosed with cancer of the breast. You have to counsel such patient properly because you know why? What will happen when you're pregnant? You have cancer of the breast. What option do you give the patient and why? You want to answer that question now or you want to do as a homework and submit to me? Kalau tak jawab sekarang, kena buat homework tau. So, jawab sekarang. Hello? You're still there?
Doctor, is a question if she wants to
I'm just asking you, why is pregnancy a prognosis?
terminate the pregnancy and then she can go ahead with chemo?
What happened in pregnancy?
Maybe because in pregnancy there's an increase in hormones, so that will probably lead to increased proliferation of the tumor cells.
Yes, exactly.
Especially estrogen.
How do you advise your patient? What do you think the patient will ask you?
Is it
If the baby would get cancer.
Not really. Before the baby is born, let's say she's about like 5 months. Okay, that's beside the point. Any other more important aspect? You think she will live if you do not remove the breast? You think she will survive the breast and the baby?
Very unlikely.
Why? She might succumb to the disease before she even deliver a full-term baby.
Yeah.
So what option do you give her?
Mastectomy.
Do a mastectomy.
Okay. Then next, what do you do after mastectomy? You have to give chemotherapy, right?
Yes, but then wouldn't the chemotherapy agents also may have teratogenic effect on the...
Yeah. So what
maybe the safest option will be radiotherapy, or more localized.
No, they will not address.
To give her a choice of either she chooses to keep herself safe or the child safe. So either an abortion or...
Yeah. Crudely put, she can have both lah. She has to choose. Survive, take away the disease and survive, but at the expense of termination of the pregnancy. But this is very complex lah. We leave to expert, but this is a point that you have to take note. We do have cases, patient pregnant with cancer of the breast, so it's a very tricky issue there. Anyway, right? Okay, your thoughts are correct. Okay. Of course, the other prognostic factor are staging. This one I will not elaborate. I'll give you some slides just to show you how staging is done, but we'll not talk about it in this lecture. Right, I think we are coming to the end. As how you diagnose is BSE, breast self examination, clinically can be done by the patient. The patient can go for routine checkup. The other thing is sometimes when they have complaint of some lesion or mass, you do ultrasound, mammogram, you follow up with other excision biopsy or FNAC, right? This is what I said just now, okay? Doing FNAC is more simple than a true cut. It's just like, have you seen how blood is taken? Yeah, it's very simple, right? You just take a syringe, put a needle, and poke, and you get blood out. That's almost exactly how we do it is FNAC. It's done by pathologists. Sometimes clinician does it, but in HKL, the pathologist go and do it. They go to the patient at the clinic and put in a needle and take out cells. It's quite a good procedure that is not so invasive. It's quite simple. You don't even require anesthetic, local anesthetic, right? This is how you do it. Just the cell that you suck in the syringe, you spread, you stain, and there on the spot, you could do it. You could look at it under the microscope. So it provides an instant guide as what to do next to the patient. Right? This is what it looks like under the microscope. You smear, just like doing a blood smear. Okay, it's on the spot. Right? All this staging, this one you learn more in clinical years. TNM staging, which T represent tumor, so those are the details. And then lymph node. M is metastasis, right? So basically, okay. This actually summarize what the earlier slides. Okay. I can go back and read about this. This is another classification by AJCC, basically looking at tumor, node, and metastasis. But AJCC is American Joint Committee of Cancer, AJCC. So they've got their own classification, which is actually very similar. Okay, we'll not talk about surgery, treatment. Okay, this is how you do. Just bear in mind there are other issues when you deal with cancer of the breast. Prognosis is excellent if only the diagnosis is made early and you treat immediately. What happens sometimes in practice, you get a patient diagnosed at early stage, but the challenge, patient refuse treatment. I'm not sure why, but most the opposition to resection or mastectomy usually comes from the husband, not from the patient. So guys, I think you got to educate your counterpart out there, the layman. So I'm not sure why, but it's sometimes quite sad. Patient had early diagnosis but refused resection because of spouse refusal, and the disease spread, get worse. So sad for the patient. But this is a real issue that you would deal with when you have such patient, especially when you are the surgeon dealing with patient. Sometimes I don't know whether this is cultural, ignorance, denial. Of course, you have to fight with other so-called complementary medication. You know how rampant things are now through the social media? Did you notice that? People are claiming this herb, that herb can cure or treat a whole list of everything under the sun, which is virtually, I think, is impossible lah. So these are the challenges that you face when you practice as a doctor one fine day. Okay. Right. Okay, we're done with cancer of the breast. Any question so far? Anyone want to put up your hand? Tanya soalan? No? You can go back and digest the whatever today's lecture, and anyone feel free to ask me any question. Okay, don't forget that apart from breast cancer, sorry.
From the case 4 in the earlier class, she had a less lump at the left breast. But why the mastectomy to the right breast?
Sorry. Complaint of lump in the left breast. And then mastectomy of the right breast?
Yeah, the case 4.
Sorry, I didn't get that part. What for?
The case 4, from the case 4.
Oh, that case 4 had a recurrent. She first had the cancer in the left side. That was removed, had mastectomy, chemo, radiotherapy, well. But I think about a year later, she developed a mass on the other side, the normal side earlier. So she had a recurrence. She had a repeat of the cancer in the other breast. So she has lost both breasts. Yeah. Clear? Is that clear to you? Sorry for the confusion earlier. Anyway, all right. Where were we? Done with cancer breast. Don't forget there are other tumors. Sometimes patients present with similar skin lesion, breast lump, and when we do a biopsy, we found that it's not actually all those typical ductal or epithelial tumors. It turned out to be this. It can be lymphoma, Yeah, we had lymphoma of the breast primary, not because of the blood or lymph node elsewhere. It's actually coming from the breast. Because the breast has also got lymphocyte. So those actually can give breast. It's not common, but it can happen. Sarcoma, which is actually tumor of the surrounding tissue. And of course, another common situation is where they have cancer of other organs, let's say GIT. Now they have it in the breast as a metastatic tumor. Yeah. Okay, so we have come to the end. All these I highlight, you all must know, Fibrocystic risk factors, the types, which one is a good one, bad ones, grading, how we do it, prognosis factors. Don't forget, you guys can also have carcinoma of the breast, primary and primary, presenting breast mass. We have cases in HKL. We have. It's very rare, but it does happen. So remember that, guys. You are not spared. You can have carcinoma of the breast.
Prof.
Okay. Yeah.
Is it true? If a guy have breast cancer, it's much more critical than woman.
I have no personal experience of treating such a patient. That's a question you have to reserve and ask your clinician, because it's very rare. I don't have the statistic in Malaysia, and I don't have personal experience. But they actually are treated the same way. Those cases that we have actually they behave just like ductal carcinoma of the breast of the female. So I think you can reserve this patient to your clinician later on when you do surgical posting. They might have the experience, but it's very rare. Data not that much, but it's very rare. But just that, to note to you that it can happen. Doesn't mean you're a guy, you're not spared. You're spared, sorry. Okay, the rest are all my notes that I say I will give you just to be aware. There are other lesions that is not cancerous. This one you take home and read up. Okay, we are done. We do cases that was actually diagnosed clinically as cancer. Once I had the experience of quite a young lady presented with breast problem, painful mass, not well defined, and in the end, because it's so cumbersome to her, such a problem because painful and quite disturbing her lifestyle. So actually, she was suspected, she was diagnosed as cancer breast, and they actually removed the whole breast. So it came to the lab to us, and actually I think we took sampling almost the whole breast. We couldn't find any carcinoma. It's just inflammation. So be careful on that as well, because if patients are educated enough, they can actually sue you for mismanagement. Yeah, be aware. That's why I just highlight all these inflammatory conditions for you to be aware. There's such a thing that can confuse you. Okay, that's it for today. Thank you very much. We are done.
Thank you,
Go
Prof.
for your lunch. Anyone any question, feel free to message me. Okay.
Thank you, Prof.
All right, doctor.
Okay.
Okay, thank you.